Welcome to this educational video about intussusception, a serious condition affecting the digestive system. We'll explore what it is, what causes it, how it's diagnosed and treated, and what the outlook is for those affected. This video is for informational purposes only and should not be considered medical advice. Please consult with a healthcare professional for any health concerns. The exact cause of intussusception is often unknown, especially in children. However, some factors can increase the risk. In children, a viral infection like rotavirus that causes swelling of the lymph nodes in the intestine might trigger it. These enlarged lymph nodes can act as a lead point, being pulled into the intestine and initiating the telescoping process. In adults, intussusception is more often caused by an underlying condition like a tumor, polyp, or Meckel's diverticulum, which acts as a lead point. Intussusception occurs when one part of the intestine, often the ileum, slides into another section of the intestine, typically the colon. Think of it like collapsing a telescope. This telescoping effect can block the passage of food and fluids through the intestine. Even more critically, it can compress the blood supply to the affected area. This constriction of blood vessels can lead to swelling, inflammation, and ultimately, if left untreated, to tissue damage, perforation, infection, and even death of the bowel segment. This is a medical emergency. Intussusception primarily affects infants and young children, usually between 6 months and 3 years old. While it's relatively rare, it is the most common cause of intestinal obstruction in this age group. There is a slight male predominance. The occurrence of intussusception tends to be more frequent during certain seasons, particularly in the spring and fall, possibly linked to increased viral infections. The signs and symptoms of intussusception can vary, but some common indicators include sudden, loud crying spells in a healthy infant, often with the baby drawing their knees up to their chest. These episodes can come and go every 15 to 20 minutes at first. Other symptoms include vomiting, which may initially be bilious, and the passage of stool mixed with blood and mucus, sometimes described as currant jelly stool. A sausage-shaped lump might be felt in the abdomen. In some cases, the child may be lethargic or weak between episodes of pain. Diagnosis of intussusception typically involves a physical examination, a review of the patient's medical history, and imaging tests. An abdominal ultrasound is often the first-line diagnostic tool. It can usually reveal the characteristic target, or Donut sign representing the intussuscepted bowel. An air enema or baryonema is both diagnostic and often therapeutic. Under fluoroscopic guidance, air or barium is gently introduced into the colon, which can often unfold or reduce the intussusception. If these methods are unsuccessful, or if the bowel is perforated, surgery may be necessary. While the term intussusception encompasses the primary definition we've discussed, understanding the location of the intussusception is key. Ileocolic intussusception is the most common type, where the ileum telescopes into the colon. Other less common types include ileoileal siam into ium, collicolic colon into colon, and rarely jejunal or jejunolial intussusceptions. The initial treatment for intussusception is typically a non-surgical reduction using an air enema or a barium enema. This is performed under radiological guidance. If the enema is successful, the child is monitored closely for recurrence. If the enema is unsuccessful, or if there are signs of bowel perforation, peritonitis, or the child is too unstable for an enema, surgical intervention is required. Surgery may involve manually reducing the intussusception, or if the bowel is damaged, removing the affected segment. Following either enema reduction or surgery, the child will require supportive care, including intravenous fluids and pain management. Unfortunately, there's no guaranteed way to prevent intussusception, especially in children where the cause is often unknown. Rotavirus vaccines have been associated with a slight increase in the risk of intussusception in some studies, but the benefits of vaccination generally outweigh the risks. Prompt diagnosis and treatment are the best ways to prevent serious complications. The prognosis for intussusception is generally excellent with prompt diagnosis and treatment. The vast majority of children recover fully without long-term complications. However, there is a risk of recurrence which occurs in about 5–10% of cases, but can be treated similarly to the initial occurrence. Recent research is focusing on identifying the specific factors that trigger intussusception and improving diagnostic accuracy to allow for even earlier intervention. Research also aims to explore if there are any genetic components that may be a risk factor for intussusception.